الله لا إله إلا هو الحي القيوم لا تأخذه سنة ولا نوم له ما في السماوات وما في الأرض من ذا الذي يشفع عنده إلا بإذنه يعلم ما بين أيديهم وما خلفهم ولا يحيطون بشيء من علمه إلا بما شاء وسع كرسيه السماوات والأرض ولا يئوده حفظهما وهو العلي العظيم. الله
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله صلى الله عليه وسلم. Welcome in our third day in the 10th SGH Rheumatology Symposium. It's our pleasure and honor to have you all in our last day in the symposium. It gives me pleasure to start my presentation. بسم الله الرحمن الرحيم. Today my topic, rheumatology is a calm branch, a very calm branch, but by time I discovered it was not. Rheumatology more deep than I thought, more vague than I understood, more complicated. Today my topic, I need to address appropriate serologic testing to evaluate rheumatic diseases or clinical utility of common serum rheumatological tests or the interpretation of investigations in rheumatic diseases, or making sense of rheumatological investigations, or laboratory testing in the rheumatic diseases, a practical review. They are more than a topic for the same autoantibodies, the double-bladed sword. This is the most suitable topic for the diagnosis and the patient. If you can catch the diagnosis, you will save the patient. If you will not catch the diagnosis, you will harm the patient and lose his diagnosis. من الشعر ظننت بهم ظنا جميعا فخيبوا رجائي وما كل الظنون تصيب. We'll take a case scenario to clarify my aim with the presentation. A 23 years old woman referred to your clinic to rule out SLA. She has no manifestations of arthritis, photosensitivity, skin rash, oral ulcers, pleurisy, hair loss, or even arthralgia. By family history, she has an aunt with Sjogren's disease and a cousin with lupus. the physical examination completely within normal limits. The laboratory done outside came back with ANA positive, low titer 1 to 40, and she does not. Does she have SCB or not? This is your task. It is really difficult to answer by only the blood test. By introduction, inflammation is the hallmark of the rheumatic disease. It has an aim. Tissue injury response promotes several modifications, which result in the aims of the inflammation: to eliminate the offending agent, to limit the tissue damage, and to restore the affected structures. But sometimes the inflammation is more and can harm. Such modifications depend on the increase or decrease of the serum concentration of certain proteins known as inflammatory biomarkers, by which we can measure the degree of inflammation. Laboratory tests can assist to monitor both the disease activity and the treatment response. The most famous are the ESR, the CRP, and the autoantibodies, which we'll discuss today. These are the inflammatory biomarkers, either positive or negative. Positive means increase with inflammation, negative means decrease by inflammation. As you see, it is a long list. The negative inflammatory biomarkers, mainly the serum albumin, alpha fetoprotein, insulin growth factor, and the factor 2. The clear characteristic pattern of inflammatory biomarkers, as you see, in the first days can increase. Some ones increase fastly, like the C-reactive protein. Some takes time, like the fibrinogen and the haptoglobin, and then returns to normal after the resolution of the inflammation. So costly. Such tests are so costly, ranging from the ESR, the most cheap, till the extractable and the autoantibodies, ANA, anti-DNA, extractable, and even the gene HLA-B27. Usefulness of laboratory tests in assessing rheumatic disease comes after the history and physical examination. This is an example to show you the importance of the inflammatory markers. For example, mechanical back pain has normal inflammatory markers. Fibromyalgia as well, the same, normal inflammatory markers, ESR, CRP, rheumatoid factor, ANA. While the connective tissue diseases come back with highly elevated inflammatory markers, namely ESR, CRP. While the gout will have high uric acid and the synovial fluid analysis are important in diagnosis. In ankylosing spondylitis, the gene HLA-B27 can help to diagnose. We'll start with the most famous, the ESR, erythrocyte sedimentation rate. Many factors can influence the ESR. Some can increase the old age of the female gender, even pregnancy, even anemia, and the elevated fibrinogen level, such as infections, inflammations, malignancy. It's non-specific. Some can decrease the ESR, extreme leukocytosis, polycythemia, sickle cell anemia, and any protein abnormalities. ESR is an indirect measure of acute phase reactant. It is non-specific. It's not very sensitive or specific. Must take its range in diagnosis, not to magnify and not to ignore. This can be useful to monitor and diagnose inflammatory arthritis. The more specific, the C-reactive protein, is protein synthesized by the liver. It increases in the acute phase response as an acute phase reactant. Its role is not fully understood, but it seems to have a pro-inflammatory effect. As you see, C-reactive protein can rise quickly and fall quickly than the ESR. Is a direct measure, highly more specific and sensitive than the ESR, and also cannot be affected by factors that can affect the ESR, like the age, gender, and the main topic today about the autoantibodies. You must catch this flower and do not harm your hands by the spikes. This is diagnosed and this is the autoantibodies. Autoantibodies are simply an immunoglobulins that binds to antigen originating from the same individual. We call it autoantigens. The autoantibodies are secreted in response to autoantigens, the self molecules. But many autoantibodies are associated with autoimmune diseases, but no known pathogenic role of any disease. By history, some are discovered recently and some are very old, till the late 50s. And even the rheumatoid factor is the first one to be described. ANA, DNA, rheumatoid factor will not lead you to the diagnosis. This is my message today. Autoantibodies are so many: ANA, anti-double-stranded DNA, anti-single-stranded DNA, anti-histone, anti-Smith, anti-RNP, anti-Rho, anti-La, anti-ribosome, anti-centromere, anti-topoisomerase 1, anti-Jo1, C-ANCA, P-ANCA. A long list. If not used wisely, you will miss. Sometimes the tests come with equivocal, maybe negative, weakly positive, weakly negative, positive. A silly dilemma. You must do your aim for diagnosis and select them wisely. Is the very important message. History taking, number one. Clinical examination, number two. Your lab investigations, number three. History and clinical examination catches about 90% of the diagnosis. Such investigations can help and can confirm your diagnosis. The American College of Rheumatology published a nice paper about wise guidelines for immunological laboratory testing in the various rheumatic diseases. They said these lab tests, autoantibodies, immunological laboratory results, can play a critical role in the care of the patient. It can help. It can define the immunopathophysiciological etiology of the disease. It can support your diagnosis. It can guide to monitor both the disease activity and response to treatment. It can predict the disease activity and end organ involvement and prognosis. But take care. They can misuse. By misuse, you can miss the diagnosis. Be cautious. Improper application of these tests can result in misdiagnosis, inappropriate therapy, and unnecessary healthcare expenses. As we said before, they are so costly. The most famous of which is the anti-nuclear antibodies, the ANA. The most likely in diagnosis. Prevalence, according to the titers. The low titers are very prevalent, up to 1/4 of the healthy normal population can be positive and can carry low titer positivity for any ANA. When the titer increases, still there is some positive people in the normal individuals, 160 in about 5%. Even the high tests are positive. Even the healthy relatives of an SCD patient can carry a positive ANA, but usually the low titer. Even elderly people, normal people, can carry a positive ANA titer, about 70%. ANA is positive in many rheumatological diseases, namely SLE, Sjogren, mixed connective tissue, even non-rheumatological as autoimmune hepatitis, primary pulmonary hypertension. It is non-specific. ANA carries several patterns: homogeneous, heterogeneous, peripheral, speckled, centromere, nucleolar. Without detailing, every pattern can address a diagnosis. As we mentioned, they are positive in many diseases, rheumatological and non-rheumatological. ANA is a non-specific test, can be positive in rheumatic and non-rheumatic diseases. It is excellent in diagnosis if targeted. When used correctly, they can provide a valuable diagnostic and prognostic information. But it is nonsense if alone. Must be kept in mind that their presence or absence alone can neither rule in nor rule out any particular disease. As we mentioned, if ANA positive, the next step will be extractable nuclear antigen, which will check which one of the ANA is positive. Anti-Smith, anti-Rula, anti-Stone, anti-centromere, anti-DNA. Every pattern can be positive in a disease. The most common of which is the SLE. When there is a strong clinical suspicion in a patient with SLE, ANA is the best diagnostic tool. But keep in mind, should not be used as a test to rule out. It is not used for screening. If ANA positive in other diseases, it can depend on the clinical setting. Then follows the test for antibodies for the double-stranded or extractable nuclear antigens after the positive ANA result. Take care. ANA is not related to the disease activity. Therefore, serial ANA testing is of unknown value in such patients. This slide will be repeated in the next days also. So, serial testing for specific antibodies such as anti-double-stranded DNA may have a clinical utility. We have a famous disease entity related to the SLE named drug-associated or drug-induced LE. ANA should be saved for patients with symptoms. Symptomatic patients only can be screened for positive ANA. Also, the repeated slide, no correlation to the disease activity, no correlation to the prognosis. You cannot monitor by ANA titer only. Our famous disease, systemic sclerosis. If patients are suspected to have a systemic sclerosis, ANA should be tested. Otherwise, no. Also, ANA titer is not correlated to the disease activity. So the serial ANA testing is invaluable. Some specific tests can be ordered after the positive ANA, like the anti-SLE70 and anti-centromere. They may carry a prognostic value. The third disease is the inflammatory idiopathic muscle disease, polymyositis, dermatomyositis. ANA, in fact, has weak evidence in both of these diseases. They are weak evidence. ANA is not useful for diagnosis for polymyositis or dermatomyositis, but it can help if there is an overlap with this. Also, no correlation for the titer with the disease activity. Thus, follow-up titer is invalid. Sjogren disease or Sjogren syndrome, this is a dry disease. ANA testing is not useful for diagnosis, but it can help to clarify. The ANA titer also is not related to disease activity. ANA is a phenomena by itself. ANA titer or ANA positivity or ANA test is nonsense. Phenomenon is the physical is not a disease. It is a physical vasoconstriction of the blood vessels of the periphery upon exposure to cold weather. But the Sjogren disease, secondary with mostly the scleroderma, it can help. If ANA can be tested only in symptomatic patients. If you are suspecting an underlying connective tissue disease associated with rheumatism. Mixed connective tissue disease is a disease entity. If you are suspecting mixed connective tissue disease, you can request the ANA testing, specifically for the RNA. Also, ANA's titer is not related to the disease activity. The GIA, same, ANA testing is not useful, but it is only useful if you are suspecting or waiting for the uveitis. ANA positive patients have high incidence for uveitis in such patients. The ANA can stratify the risk of uveitis in patients with this. Rheumatoid arthritis positive ANA is not uncommon. We have up to a quarter of the patients of rheumatoid arthritis with positive ANA, but it is not related to these activities. Conclusions related to the ANA by itself, the most commonly used, commonly requested autoantibody, positive ANA testing is associated with a number of systemic rheumatic disease as well as various other conditions. The ANA test has greatly assisted in the diagnosis of these both diseases, SLE and systemic sclerosis. Take care, it is not used for screening. The false positive rate associated with these tests limits its usefulness as a screening test for rheumatic diseases. The son of the ANA is the anti-DNA antibodies, namely the anti-double strand. It is very useful to diagnose SLE. The titer gives a strong support for the diagnosis of SLE, but a negative test does not rule out. Therefore, it is a good positive, can help the diagnosis, but its absence cannot rule out. It is a bad negative. Here is an exception for the antibody testing. Anti-DNA, namely, is correlated with the lupus activity, specifically for the lupus nephritis. It can correlate with the activity of the renal affection in SLE. As long as the titer is high, strong association with lupus activity and lupus nephritis. But it does not predict the flare of the disease. The less used antibodies, anti-SLA70, anti-centromere, anti-nuclear with systemic sclerosis. The guidelines that is very useful in diagnosis for systemic sclerosis. They can predict the noisy side of the disease, the skin affection, as well as the dangerous side of the disease, the pulmonary affection. ANA, anti-nuclear is positive in about a quarter of the patients with scleroderma, but is low sensitive but highly specific. You must use this wisely. It is useful in the skin involvement with limited. It is useful to detect the main cause of death in such patients, the pulmonary fibrosis and the restrictive lung disease. Anti-Smith, anti-RNP antibodies are useful for the diagnosis also for SLEs, namely anti-Smith. But it does not correlate with the disease. It does not correlate with the disease activity, namely the renal, as the anti-double stranded. RNP is positive in mixed connective tissue disease. If you are suspecting, you can request an order. If not suspecting, do not request it. Anti-Rho, anti-La antibodies are highly supportive for the diagnosis for SLE as well as the Sjogren disease. In the SLE, it can be associated with photosensitivity, cutaneous vasculitis, eyelid. But about 75% of primary Sjogren can be positive, and about 15% in secondary Sjogren can be positive. It has a specific importance in predicting the neonatal lupus syndrome to avoid its major complication, the congenital heart block in such patients. Approximately 80% of babies born with congenital heart disease for mothers with SLE can carry the positivity for anti-Rho anti-Rho. SSA, SSC. Rheumatoid factor. Rheumatoid factor is the first one to be described in this array. It can help for the diagnosis of rheumatoid arthritis, but as you see, it is positive in many diseases, rheumatic and non-rheumatic diseases. The sensitivity for rheumatoid factor in rheumatoid arthritis about 50 to 85%, but its absence does not rule. As well, rheumatoid factor alone cannot make the diagnosis for rheumatoid arthritis. Yani any patient with joint pain carry the positive rheumatoid factor does not have the diagnosis for rheumatoid arthritis. It can help. As you see, 5% of normal population, healthy population, can be rheumatoid factor positive. We call it seropositive. Even in rheumatoid arthritis, we have seropositive rheumatoid, about 70 to 80% of rheumatoid arthritis patients, and seronegative rheumatoid means the rheumatoid factor is negative, about 10 to 20% of rheumatoid arthritis patients. It's positive in Sjogren, mixed connective tissue disease, SLE, and even in hepatitis C virus infection. It can predict there is erosive changes in the radiological assessment and to less extent in the elderly patient. Anti-CCP is more specific, more sensitive, more specific than the rheumatoid factor. Its presence can confirm the diagnosis of rheumatoid arthritis. Its absence, like rheumatoid arthritis, like rheumatoid factor, cannot execute. In short, بمن يثق الإنسان فيما ينوبه ومن أين الحر الكريم صحابه. احنا خلاص هدمنا we destructed already the false building of autoantibodies if not used wisely. Clinical assessment is the cornerstone. Again, clinical assessment is the cornerstone for the diagnosis. اليوم أي الطبيب يعني. اليوم حاجتنا إليك وإنما يدعى الطبيب لساعة الأوصاب. يعني the physicians will carry the diagnosis, not the laboratory tests. Choosing wisely, an initiative from the American College of Rheumatology to choose wisely the various tests, either radiological or laboratory. The first one of which do not test ANA sub-serologies without a positive ANA and clinical suspicion of immune-mediated diseases. ANA is not used for screening. Do not order auto-antibody panel unless positive ANA and evidence of a rheumatic disease. This is many recommendations, but this is the most important of which. In short, donuts in rheumatology, except with the exception for anti-double-stranded DNA, as we mentioned in lupus nephritis, do not repeat ANA sub-serologies, even the ANA itself, in patients with established connective tissue disease diagnosis, because no correlation with the disease activity. Do not perform serial measurements of rheumatoid factor and anti-CCP in patients with documented seropositive rheumatoid. Same for the SLE patients. Do not order serial ANA testing. Nonsense. Do not order HLA-B27 unless you suspect an undifferentiated spondyloarthropathy based on history, as we mentioned, and examination, but no radiological radios. We call it non-radiography. Do not order an MRI before ordering plain X-rays in a patient presenting with joint or back pain. The only exception are early, very early arthritis, before 3 months. In summary, good history taking and complete clinical examination are the cornerstones for diagnosis, not the lab testing. Laboratory tests should be used wisely to confirm your clinical diagnosis, not to make it. Laboratory testing are not the gold standard for the diagnosis of autoimmune illness. autoantibodies may be associated with a particular disease process. Their sensitivity and specificity vary widely. They are adjunct used in combination with both the history and physical examination. Each rheumatic disease has a set of criteria used to make the diagnosis of that particular disease process. A lab test is just a small portion of it. Normal individuals may have positive autoantibody testing insignificantly without any disease process. None of these tests is perfect. Therefore, history is your main tool. Examination with the history will catch up about 90% of the diagnosis. Then the investigations can confirm your diagnosis. You must be targeted. Selective ordering can improve the clinical usefulness and cost effectiveness of serum rheumatological diseases. These tests should be ordered and interpreted cautiously and only within the context of the patient's clinical situation and the clinical picture you thought it in your mind. Never to order a panel. Use less, if not harmful, such tests. Confirmatory, not for your clinical impression. In general, rheumatological tests are most helpful in confirming a clinical diagnosis. Several tests are also useful for prognostic ones. As with all tests, physicians need to be familiar with the predictive value and implication of a positive result. Final advice: why you are ordering it and what you will do if it comes back abnormal. You must ask yourself these two questions: why you are ordering the blood test and what we will do if it comes back abnormal. Do not order any laboratory test unless you know the answer of these two questions. My final advice: do not order any. I mentioned it a lot, sorry, but we are suffering in the clinical practice from non-specific testing and to answer every patient for if it is significant or insignificant. فمعلش استحملوا. Do not order any laboratory test unless you know why you are ordering and what you will do if it comes back abnormal. Take home message: ذو الحزم لا يبتدي أمرا يهم به حتى يطالع ما تبدو عواقبه. واضح. وأحسن منها قول الله تعالى: فمن يعمل مثقال ذرة خيرا يره ومن يعمل مثقال ذرة شرا يره. جزاكم الله خيرا وسوري for the long time for the lecture. If really the patient came with only family history and afraid of the autoimmune disease, but only to follow up. We are not treating the family. We are treating the patient. We screen the patient clinically for any clinical abnormalities by symptoms and signs. If you are suspecting, you can order the blood test guided as we mentioned. Does COVID vaccine contribute to high need? Yes, it can. It can be related to the high titer. If it is significant or significant, it will depend upon the clinical data. How the diagnosis can be confirmed, as we mentioned: history, examination, and investigations. It is very difficult for me. I have a lot of signs and symptoms for 1 year and no confirmed diagnosis. You must visit a rheumatologist in such cases. Thank you so much. Inshallah, we'll shift to our second lecture. My dear friend, Dr. Muhammad Samir, is the head of Physical Therapy and Rehabilitation Department, Saudi German Hospital, Riyadh. He will give us a nice, interesting topic about the evidence-based practice for managing plantar heel pain.
Assalamu alaikum. First of all, I'd like to express my appreciation and my gratitude to my mentor and my professor, Dr. Khalid Fathi, rheumatology consultant. Please accept my sincere congratulations on such a successful symposium organization, and thanks for Saudi German Hospital Riyadh Management, especially Academic Affairs, for such support. Today, we will talk about evidence-based practice for managing heel pain and plantar fasciitis. Okay. Today's outlines for our lectures is 5 elements. First of all, definition and the prevalence. Second one, anatomy and biomechanics of the foot. Third one, the cause and risk factors. Fourth one, examination. Fifth one, clinical guideline and intervention. Heel pain and plantar fasciitis is a term used to describe the pain arising from the insertion of the plantar fascia with or without heel spar. Actually, 26% of people has calcaneus spar or heel spar are asymptomatic. And the population for prevalence for plantar fasciitis and heel pain has been reported about 10% of all the population. It's a huge number for such a chronic problem. In the basic, we are talking about the anatomy of the foot. Foot and ankle joint are a complex structure, consist of 26 irregular shaped bone and 30 synovial joint, more than 100 ligament, and 30 muscles acting in that segment. Foot has a move in 3 planes, and its function to support the weight of the body in standing and the locomotion, and act as a shock absorber. There is a nerve supply for the foot and ankle. The most important ones are lateral plantar nerve, medial plantar nerve, sural nerve, saphenous nerve. And this is a dermatome coming from the lumbosacral plexus. What is the plantar fascia? It is a thick connective tissue which supports arch of the bottom of the foot, and it runs from the tuberosity of the calcaneus bone forward to the head of the metatarsal bone. And this is the shape of the plantar fascia and aponeurosis. It's running from the calcaneus, as it shows here, till the toes. And this aponeurosis thickness, usually by ultrasonography, from 3 to 3.5 millimeters in a normal, in the mean thickness for male and female adult. And if it's more than 4 and 4.5, it will be abnormal plantar fascia and has an inflammation. Plantar fascia has an important role in dynamic function during the gait. Plantar fascia is continuously elongated during the contact phase of the gait. It went through rapid elongation before and immediately after mid-stance, reaching the maximum of 9% to 12% elongation between the mid-stance and toe off. Plantar fascia has a critical role in a normal mechanical function of the foot, contributing to what they call windlass mechanism, which is very important role, very important mechanism. When the toes are dorsiflexed in the propulsive phase of the gait, the plantar fascia become tense, resulting in elevation of longitudinal arch and shortening of the foot. And this picture shows how the foot is demonstrated as a triangle. This triangle is consisting of the 3 truss. The first truss from the calcaneal bone to the midfoot, and the midfoot to the metatarsal bone, and the last one, the plantar fascia itself. And it's elongated when we put the weight bearing of our body in the foot, it's from 9% to 12%. When we do propulsive gait and the phase from the mid stance to the toe off, there is a movement of the grade 2 dorsiflexion, which make a shortening of the plantar fascia, increasing the arch increasing the arch height and fixing and shortening the foot itself. And this is how amazing such mobile structure can be firmed and fixed in the certain phase of the gait cycle. And this video will make a demo for the windlass mechanism, so you can imagine what we are talking about.
The medial longitudinal arch is central to the foot's windlass mechanics. The truss of the arch is formed by the calcaneus or heel bone, the mid-tarsal joint, and the first MTP joint. The plantar aponeurosis forms the tie rod that spans from heel to toes. The attachment of this aponeurosis to the toes beyond the MTP joint forms the basis of the windlass mechanism. When the big toe is dorsiflexed during walking, the aponeurosis winds around the first MTP joint and pulls the heel and toes slightly closer together, raising the medial longitudinal arch and locking the bones of the foot. It's an ingenious way of stiffening the foot and converting the supple landing foot into a rigid propulsion foot. In this example, the distance between the heel and the toe is shortened from 4.8 units to 4.5 units. The windlass mechanism does not occur when wearing shoes because shoes do not allow movements in the foot, like toe flexion and extension.
Now we go through the causes and risk factors of plantar fasciitis and heel pain. First one, the obesity. The body mass index, if it's greater than 30 kilogram per meter square, it will increase the risk factor of developing plantar heel pain, especially in a woman more than men. Occupational, this is the second one, association with the plantar fascial pain or heel pain, prolonged standing or walking, like a occupation has standing along, like a policeman. Third one, the acute injury. Although it's less common, plantar heel pain may be associated with an acute injury of the heel. Some people recall stepping on the pebble or other hard object before the pain began, like a stone bruise. Anatomical, the heel pad is specially constructed as an efficient shock absorber to attenuating peaks in dynamic forces and dampening vibrations. So we are there's two studies for this characteristic, which is the thickness and compressibility index, which will describe the load and sorry for inconvenient disconnection. Back again for the causes and factors. We are talking about the biomechanical causes, which is most important causes and risk factor. People with the high arches like a bis cavus or low arches like a bis planus instead increase the risk factors because they increase the repetitive stress being placed on the fascia. Shortening of the calf muscle and Achilles tendon make excessive rear foot motion, especially overpronation or rigid varus hand foot, maybe also put the patient at risk by placing excess stress in the plantar fascia. Last element in the biomechanical cause decrease the dorsiflexion range of motion or weakness of intrinsic foot muscles, as has also been cited as a cause of these factors and may increase the moment of maximum tension in the fascia. So the intrinsic muscle fiber of the foot has this rule. Also, the tibialis posterior muscle has a highly important role in supporting of the medial arch. Inflammation of this muscle can occur through repetitive use, such as high impact sport like volleyball, like basketball. When this tendon become inflamed, resulting from trauma or hard fall, this tendon become inflamed or even tear. It's immediately cause pain and in the foot arch. And neglected this case, it may be gradually collapse and cause a flat feet. And this picture shows how we demonstrated the curvature for the foot as a bis planus or neutral or bis cavus according to the talo-metatarsal angle. To define this angle, it will help us to diagnose which is the shape of our foot. And this also demonstrates oversupination and overpronation for the foot. Other causes and risk factor, we have a calcaneus stress fracture. The history of calcaneus stress fracture is usually involved of sudden increase in running activity. Also, nerve entrapment, we have a most important nerve is Baxter nerve. If it's trapped, it may making pain at the plantar fascia. And it can be trapped between abductor digiti quanti muscle and the quadratus planti muscle. So we have to do Tenel sign test on the medial aspect of the heel to check the suspicious entrapment of the nerve to abductor digiti minimi, the Baxter nerve, or tarsal tunnel syndrome. This picture shows a Baxter nerve, which is supplied for abductor digiti minimi, the first of lateral plantar nerve, and it carries pain and sensation in the plantar fascia. Baxter nerve can get trapped between the abductor hallucis and the quadratus planti muscle. And this is the Baxter nerve. One of the risk factors and causes also tumors in the area are quite rare, but presenting a palpable mass or bony erosions of the calcaneus. Infections in the other part of the body, there will usually be some swelling and erythema and history of malaise and fever. Neuropathy, even diabetic or alcoholic patient have a history of burning, pain, and numbness and paresthesia and can be confirmed by neurological examination. Now we go through the clinical practice guideline. Who makes the judgment for clinical practice guideline? It's who all the clinician supporting for such cases, for rheumatologist and orthopedic and sports medicine and researcher and physiotherapist, every healthcare provider dealing with such chronic case. And this is how we categorize the evidence-based practice from 1 to 5 level. The first one is the high evidence quality diagnostic study. Second one is evidence obtained from the lesser quality diagnostic study, prospective study, randomized control trial, weaker diagnostic criteria and reference standard. Third one, case controlled study or retrospective study. Fourth one, case series. Fifth one is an expert opinion. And this is a grade from the strong evidence to the expert opinion. Symbols. A is a strong evidence, having combination from the level 1 and level 2 studies. B, moderate evidence, a single high quality randomized control trial Okay, and C, weak evidence, a single level, second, and sometimes have 3, third, and fourth studies level. D, conflicting evidence, higher quality studies conducted on the topic disagree with respect to the other conclusion. E is the theoretical and foundational evidence. It's evidence from the animal and cadaver studies. And last one, F, it's means expert opinion, best practice based on the clinical experience. Now we will go through the examination. First of all, don't forget to listen to take a pain history. And any examination consists of observation. We will check the observation from the standing and supine, any abnormalities. We'll check the active and passive and resistive movement for the ankle and foot movement in the plantar flexion, dorsiflexion, inversion, eversion, toes flexion, and extension. We will do palpation for certain point to check the tenderness over this point. And then we'll do functional test for single leg stance, walking, climbing stairs, and functional assessment questionnaire. Last one is special test to confirm the diagnosis. The first special test we are talking about the ankle lung test, and this is how to describe the problem in dorsiflexion due to the overpronation of the foot. So the patient is standing against the wall and make a thumb rule between hand and the toes of the against the wall. Then he tried to reach by his knee to the against the wall, confirming his heel is firm on the floor, and measurement distance between the toes and the wall. If it's below than 9.9, it will be abnormal dorsiflexion. It will be considered positive test for lung test, ankle lung test. The other special test, navicular drop test, we are making a marker in the navicular bone. Then we make the patient put his feet without any weight bearing, then make a measurement, then relax it all the weight bearing in the foot, then measuring the difference. If it's greater than 10 millimeters, it's considered abnormal and positive test. And this is how to do windlass test. It's very important test for the diagnosis plantar fasciitis.
In this video, I'm going to show you how to perform the windlass test for plantar fasciitis. 2003 found a sensitivity of 32% and a specificity of 100% for this test in the diagnosis of plantar fasciitis. To perform the test, have your patient standing on a stool or chair with the foot positioned so that the head of the metatarsal rests on the edge of the stool while the patient puts weight on the leg. Then passively dorsiflex the big toe. This test is positive if the patient feels pain or increased pain at the insertion of the plantar fascia at the head of the first metatarsal. If the extension is not possible at the MTP joint, this may indicate a hallux rigidus. In it.
And this is a Tinel sign test.
This is going to be a 58%, but they could not provide any specificity percentage. The Tinel sign can be elicited in two places around the ankle. First, there's the anterior tibial branch of the deep peroneal nerve, which you would assess by tapping anterior to the medial malleolus. Secondly, you may be able to elicit the Tinel sign for the posterior tibial nerve by tapping behind the medial malleolus.
So any positive sign, it will be referred and tingling in the peripheral side. Now we are talking about the clinical guideline for plantar fasciitis, the new guideline prepared by American Physical Therapy Association. The updated one is 2014. The diagnosis should be checking the plantar medial heel pain the most noticeable with initial steps after a period of inactivity, but also worse following prolonged weight bearing. Second point, heel pain precipitated by recent increase in the weight bearing activity. Third one, pain with a palpation of the proximal insertion of the plantar fascia. Positive windlass test, negative tarsal tunnel test, limited active and passive pterocrural joint dorsiflexion range of motion, abnormal foot posture index score, high body mass index in the non-athletic individuals. In the diagnostic, imaging is rarely needed for the initial diagnosis of the plantar fasciitis, but can be used in neglected cases. So we are concerning the clinical assessment. Then if we need to roll out some roll out some other pathology in the heel and the foot, or checking the neglected cases, we can using the X-ray, then X-ray to checking the calcaneus spar. Even it's not related to the plantar fascial pain, because 26% of the people have the calcaneus spar are asymptomatic. Also, the ultrasonography, we're checking with ultrasonography the thickness of the plantar fascia, which is 4.5 millimeters. It's considered plantar fasciitis and have an inflammation in the plantar fascia. The third one, the most expensive, the magnetic resonance MRI image, is to check the root out of other pathology or heel bone construction. And there is the old wisdom, body comfort starts from the feet. So we'll go through the intervention. First, initial intervention, we'll advise the patient for the rest and give him the NSAIDs and activities modification. Second thing, it's night splinting. This is a limited evidence base for night splinting to treat chronic symptoms. Use orthotics. Most of the orthotics are designed to the correct biomechanical fault, especially over pronation. Using heel cups. First one, tapping, and it consists of two kinds of taping: dynamic tape, like a kinesiology tape, or rigid tape, like a Mulligan tape. As this picture shows, this is a kind of Mulligan tape or fixed tape, how to grab the heel itself, as a dynamic tape, kinesiology tape, and this is the heel cups and night splint. Other intervention, stretching and strength exercise. There is evidence-based practice, good evidence-based practice to using with the chronic plantar fasciitis. Deep friction massage, even by golf ball or tennis ball, or manual. Corticosteroid injection. Using antiphoresis with dexamethasone 0.4% and acetic acid 5%. Antiphoresis pain relief and restore function in short term from 2 to 4 weeks. Shoe modification, like a rocker shoe construction associated with the orthotics, we fix it for the patient itself. And neglected cases, we can use casting from 4 to 6 weeks in plantigrade neutral position. And this is the exercises we are doing, from stretching and rinsing and range of motion for the ankle and foot. Some intervention is interesting about extracorporeal shock wave. It's the successful rate for extracorporeal shock wave ranges from 50% to 90%, with low recurrence rate from 5 to 7%. It's non-invasive, inexpensive compared to the surgery, and the patient are usually able to resume their activity quickly and with a minimal lost work time. Extracorporeal shock waves, the physiological evidence based, provide analgesia, stimulate the healing process by removing inflammatory debris and remove new vascularization and increase the circulation. Another modality is radio frequency lesioning. It's demonstrating one needle for the nerve supply for this area, increasing its temperature by 80%, 80 Celsius, making this nerve damaged, so will not sending signal of pain again. But the patient should know it will. He need to repeat this procedure again later on after the body regenerates this nerve ending. Open and endoscopic plantar fasciotomy is a surgical solution for the neglected cases and recalcitrant cases. Now we are talking about the updated guideline from the American Physical Therapy Association, which is updated in 2014. The high evidence base using manual therapy for mobilizing soft tissue for the calf muscle and mobilization for the joint itself, and providing good articulation for the joint and provide good dorsiflexion. Stretching also has a high evidence-based practice. It gives short relief from 1 to 4 months. Taping, anti-pronation taping, give immediate relief up to 3 weeks. Orthotic device, clinician use the orthotic device, prefabricated, custom-made or fabricated one or fitted one. Now we have a 3D foot analysis to check the curvature for the foot and most point of pressure of the foot, and correction for the curve according to the analysis and topography scanning for the foot of the patient, and it will help to decreasing the pain from first 2 weeks and long term for 1 year period. Night splint has a moderate evidence. We can prescribe from 1 to 3 months program of night splint for individual with a heel pain, plantar fasciitis, and who consistently have a pain with the first step in the morning. Physical agent has a weak agent like a cold and hot packs. Antiphoresis, we can use it. Low level laser and phonophoresis and ultrasound has a weak evidence base. Dry needling and by expert using as a trigger point in the cuff we can use. Shockwave has a moderate evidence base. And this is the summary for what we are talking about, the evidence base for diagnosis. We are concerning about the clinical assessment for the plantar medial heel pain, most noticeable with the initial step after a period of inactivity, but also worsening following prolonged weight bearing. Heel pain participated by the recent increase in the weight bearing activity. Pain with a palpation of the proximal insertion of the plantar, positive windlass test, negative tarsal tunnel test, limited active and positive talocrural joint dorsiflexion range of motion, abnormal foot posture index score, high body mass index, non-athletic individuals. We are not concerning with the diagnostic unless we are diagnostic investigation like X-ray or ultrasound or MRI, only for neglected cases, and rule out some foot pathology. Okay, and examination outcome, we using this score, foot function index, and also for examination, evaluating the patient heel pain, plantar fasciitis over the episode of care assessment, using modalities like manual therapy and stretching and taping and foot orthosis and night splint. Intervention like shockwave and low-level therapy and phonophoresis ultrasound combination together give good relief. Education and counseling for weight loss, it's very important also. Intervention with the therapeutic exercise and neuromuscular re-education. Intervention by dry needling. Thank you. Thank you so much, Mohammed, for your nice presentation. This commonly seen in the clinical practice. Now with the third presentation in our third day, my dear great professor, Dr. Abdulazim Al-Hifni, is one of the pioneers of rheumatology. Dr. Abdulazim is a professor of internal medicine, immunology, and rheumatology, faculty of medicine at Shams University, with a professional topic today about the management of difficult to treat rheumatoid arthritis. The secrets. Welcome to Abdulazim.
السلام عليكم ورحمة الله وبركاته. بنشكر الأستاذ الدكتور خالد فتحي، أستاذ ورئيس قسم الروماتيزم مستشفى السعودي الألماني في الرياض، والأورجنايزنج كوميتي والسعودي الألماني كله على الدعوة الكريمة وعلى المجهودات. إن شاء الله ينفع بيكم. كده واضح
Yes.
تمام. Management of difficult to treat rheumatoid arthritis. The fate of rheumatoid arthritis, if not treated properly, will be pain and destruction, loss of function, work disability, which then be manifested in systemic disease and complications and burdened with the end of also lymphoma, lung cancer, and non-melanoma skin cancer. Targeted therapies along with early diagnosis, early referral, early demand initiation, and treat-to-target strategy have led to the improved outcomes for the vast majority of cases. And with the strategy, the EULAR recommended management, if we give the patient the first biologic and non-response, we then shift to phase 3, and we have to change the biologic demand or JAK inhibitors from a different or same class in this recommendation, and with improvement in 3 months, and to achieve the target in 6 months if the patient achieved